tremendously impacted by his loss, continue to be, and it's appropriate that we share his memory today, and I'm honored to be able to do so. Let me introduce the members of our next panel. You can see their full biographies on the program materials. But first, we have Dr. Ben Hunter, who's a psychiatrist and a medical director of Skyland Trail. We have Mr. Eric Lang, an attorney, a speaker and writer on mental health issues in the practice of law. We have with us the Honorable Wesley B. West Taylor, Judge, State Court of Fulton County, and the President of the Council of State Court Judges. And then we have Dr. Mark Swankut, MD, PhD, DTMH, staff physician for the Fulton County Board of Health, works in the respiratory clinic there, and is the Deputy Area Commander and Safety Officer for the Unified Atlanta Fulton County Emergency Management Agency. So we thank all of you for being with us today and contributing to this important program. And I trust that you will all find this next panel very compelling. Ms. Yates, I turn it back over to you. Thank you.
Thank you so much, Judge Reese, and thanks to all of our panelists for being here with us today. We're going to open this up, much as we opened up the first panel, by asking each of you what your connection to the legal community is and to suicide. And in this instance, why don't we start first with Eric, if you could tell us a little bit about that.
Thanks, and thank you for having me today in this most important session that we're having. I've been practicing in Atlanta for 30 or 20 some odd years in big and small firms in business litigation. My connection to the issue of suicide, in the early 2000s, I was dealing with undiagnosed and untreated bipolar disorder. This led to me making some stupid and risky decisions that led to some unethical actions. All of that led to, an attempt at killing myself. I guess what I can really say is the reason I'm here today is that I'm a much better lawyer than I am a pharmacist. From there, I, told the Supreme Court what I was doing, what I had done wrong, was required to take a couple of years off, took that time as was necessary to get treatment, inpatient, outpatient, get the meds right, came back to practice in 2015, returned to much of what I was doing beforehand, but with a lot more self-awareness as to what I was and was not capable of, and have really made an attempt to give back. I'm not here unless Jenny Middleman at the State Bar and if the Supreme Court doesn't say, hey, there are mitigating factors here, do go away for a couple of years, but if you get yourself better, you can come back. And this is paying it forward and helping out. And I know, I guess Bill Reinhart mentioned it earlier, every time I have this discussion, and it's been 15, 20 times in the last few years, 2, 3, 4 people come up to me afterwards, and I know I've helped them.
Well, and thank you for being here today. You're going to be helping more folks today as well. What about you, Mark?
Okay, I'll start off quickly. So yeah, the intro was read. So yes, I'm an ID doc. I work at the Board of Health at TB, and I'm very involved in COVID response. So I guess I'm here for 2 reasons. Number one, I'm a patient, and and I'm from a different profession. But the other thing is I have been involved with the legal profession, and I'll tell you how. And now I'm blanking. Oh, David Summerlin at the Superior Court in Atlanta emailed Public Health and said, can someone from Public Health come over to help us, arrange things to reopen the courts when we reopen the courts. This was long ago before we shut them down again, or before the Chief Justice did. So I said, yeah, sure, I'll do it, but I have to go over and walk through it to see it. During that time, Justice LaGrua asked me if I would be on the Judicial COVID-19 Task Force, and I said, sure, I'll do that. That sounds cool. Little did I know what I was getting into, because it was a couple weeks later, maybe a couple months later, that I realized that the Judicial Council was a statewide thing, and that it was under the auspices of Chief Justice Melton. And then I thought to myself, holy crap, what did I do? Actually, I didn't use the word crap. So what I've been doing is giving advice to the Judicial Council, and that's how I came to be involved in, basically in the participation today. But the other part is that I'm a patient who has also attempted suicide, though in a different way than Eric, and we'll get into that.
Okay. Well, thank you for that, and we'll talk more later. What about you, Wes?
Well, thank you. Well, I'm a judge on Fulton County State Court. Been there for a little over 10 years. And so my connection and the reason why I'm here is I've been on the Judicial Council through being on the Council of State Court Judges. I'm on the Judicial Council. I heard about this panel and I just randomly talked to Carlise and she said, okay, you're on. I said, oh, okay. But I am on because years ago, back in 2001, I happened to be in my hotel room preparing for a deposition that I was taking in Midtown, but we were staying at the Marriott World Trade Center on 9/11. And so I happened to be right in the center of the 9/11 attacks on the Trade Center towers. If you're not aware, the hotel connected to two towers. So it was absolutely ground zero. Saw things nobody should, and made it out after a week out of New York and made it back home. And then about a month later, ended up being divorced, well, separated and then divorced from my wife at the time. And so after that, I was in a pretty dark place for a pretty good amount of time. And I ended up, I remember there were lots of thoughts about what to do. And we'll talk about that in a minute, but I was staring down the barrel of a shotgun when I finally said to myself, well, you know what, before I actually do this and pull this trigger, maybe I should talk to someone before I do it. And so I did. I used our employee assistance program at Troutman Sanders. I was still practicing at Troutman and doing high-level legal work, but used that and then was connected with a psychiatrist. We got some good drugs on board, and then I ended up being able to make it through that time period of my life.
Well, we're not only glad you did, but so appreciate your being with us today to share this. How about you, Ben?
It's nice to see you again, Sally. I think besides having a number of friends and connections through some forensic psychiatry work in the legal community, I think the first time I was formally involved was doing a panel with you on suicide in 2019 at our Skyland Trail annual lecture. So appreciate everything you've done then and since then to promote this cause. As a psychiatrist and as a former member of the board of trustees at the American Foundation for Suicide Prevention, this is something I think about every day. I meet with patients every day who are considering suicide or have thoughts about suicide. It's a much more common phenomenon than I think anyone appreciates until you've been in this arena and kind of met with patients and spoken to people who have experienced this. So, as one of the top 10 leading causes of death in the United States, and certainly higher among certain communities, including professionals in high stress careers, this is just such an important thing to talk about, and it's a pleasure to be here and again answer some questions and help facilitate this conversation. I'm so appreciative to everyone who's willing to speak on this panel and reduce stigma and bring awareness to this topic, and as well as everyone who's joining and again participating and helping fight this fight along with us. So thanks for having me.
Well, thanks for being here. Well, you all have been incredibly candid, and we so appreciate that, about your struggles. What were some of the barriers that prevented you from accessing care? And I'm just going to open it up for whoever wants to speak.
We're all very shy.
Eric, do you want to, or Dr. or Martin, you want to
go? So barriers. Well, so let me give a little background. So Ben can talk about this more, but Wes said his was situational. And Eric can get into his in a bit. Mine is actually probably combo of biological and situational. The first time I was suicidal, I was in 7th grade. I think the first time that I, in retrospect, realized I probably was suicidal in the 3rd grade because my parents got called into a parent-teacher conference because I was withdrawn. And so I've periodically gotten suicidal through high school, through college, through medical school. In fact, I figured out that I've had depression when I was 22, when I was a first-year medical student, but didn't get help until I was 30. So, you know, the barriers to it are pretty simple. One is my family comes from the Midwest, and my father really sort of instilled and still believes that, and something you said, Ms. Yates, is that being suicidal, being depressed is weakness. You know, you're a man, you do not show weakness, and you do not go ask for help in these sorts of things. You motor on through it. So that was part of it. The other thing is that, you know, this is a long time ago. This is like 30 years ago. In medicine at that time, there's more stigma among, you know, to be depressed as a physician or a medical student or things like that, despite the fact that we had a student, a classmate of mine, commit suicide. You know, it just wasn't something that you advertised because people would treat you different. And so, you know, that was the aspect that made it difficult.
You know, this is usually the question that triggers the stigma answer. And for me, no way. I've got a belief that all of us, I don't just mean the 6 of us on the screen, I mean the 1,600 people that are out there, are brilliant. We all did well in elementary school and middle school and high school and college and law school in our profession. And we've been told our whole lives how brilliant we are, which is like saying your brain is good, your brain is wonderful, your brain has worked. So when your brain is doing something, you must assume it's part of a wonderful brain and it's working. The fact that every day I would have this Camus myth of Sisyphus discussion with myself about it, you know, should I die, should I live? That was just what my brain did. And I had no reason to know that that was bad until after the attempt, the therapist in the hospital said, have you ever thought about this before? And I said completely seriously, you mean aside from the thoughts that everyone has every day? And she looked at me as if I were crazy. So to me, the answer isn't stigma, though I would love to talk about stigma. The answer is, I didn't think I needed help.
Because that had always been your reality. Is
Yeah,
that right?
it's like you have a pebble in your shoe, but you don't know that there's always a pebble in the shoe.
Yeah, and so actually, I just to reiterate what he just said is that I didn't realize that I mean, I thought it was normal to wake up in the morning and feel worthless and feel like nobody cared and feel like nobody would miss you. And I mean, I thought everybody was depressed and had thoughts of suicide. I mean, it wasn't until later that I realized that, you know, that's kind of weird, actually, and that doesn't happen to everybody. And so, you know, what Eric just said is kind of like, that's the other part, is you don't realize that it's not normal because it's your normal.
And if I could just piggyback real quick, because just so that if folks are on here, mine, as I said, really came on situationally. And so, but even so, I also had those same thoughts of everybody's thinking about killing themselves. Of course, I was convinced that the whole world would be better if I weren't in it, and all my friends and family were going to be better off without me around. So it's really odd. And I think this is one of the things I hope people can realize. It's that piece about what y'all were talking about in the first panel of recognizing other people and thoughts. That's really hard to do because I was highly functioning. I was doing what I was supposed to do. I wasn't dropping the ball on work, or I was going out with friends. And so, but in my head, I was having these thoughts, and I thought that was normal. I thought everybody, like Eric and Mark said, like everybody thinks about killing themselves. And I was just convinced of it. And it wasn't until after I got the help that I kind of came back to realizing, wow, not everybody thinks about that.
I might be skipping, I don't know what your notes are, Sally, but I want to react to something that Wes said.
Forget the notes. We'll go.
This concept of not letting other people know and everything is okay that's going on in your head. We're high functioning. We're attorneys. We know how to communicate. We know how to use words. One thing that comes up in these discussions, these seminars, these programs, these whatever, is what could other people have seen? What do you wish other people have noticed? And I say this especially to people who've lost people. The answer is often nothing. It's inside the person's head. The person's got a mask on, and you shouldn't beat yourself up for what someone was hiding from you. Not consciously, not evilly, but that's just what was part of it. The thing for me, when people talk to me about prevention, I go straight to self-awareness and skip right over what are the signs, because the signs are just all over the place. Sorry if I don't.
So, actually, Ms. Yates, you actually mentioned like a mask, and you said that, and that's, I would say, almost an act. It was like sometimes I would, I would go in and say, okay, now I'm going to put myself in the role of doctor, and that's my act today, But we wear a mask. We put something on that doesn't let anybody see what we're feeling, and that's, at least a long time ago, that was sort of how doctors were taught to behave in front of patients, is that you're supposed to be the objective person in the room, like evaluating the data and the evidence and stuff like that. So I'm sorry to interrupt.
Oh, no, you weren't interrupting at all. I think back to my dad, and you're right. I'd mentioned sort of the facade that he could keep up around other people. But then when he would come home around the family, it's almost as if it was just exhausting for him to keep that going around everybody else, and he would be able to relax at home. And we certainly knew that he was suffering from depression, but that depression would ebb and flow. And we were always ever hopeful that in the ebbing time that it was really going to be different for him now and not come back. And I think that I at least would see him exhaust himself trying to keep up that mask or facade that you mentioned. And I have to ask you, Ben, I would imagine that none of this is really unusual that you're hearing now in terms of how people are coping, both to the outside world and how they sometimes even convince themselves that this is normal.
No, absolutely. And I think, to add in that, the distress of having to present oneself as differently and inconsistent with how they're actually feeling internally and meet other people's expectations for how they should perform in their career or in their family, it's another source of stress. And I think that you add that into the professional expectations and the stress that a lot of us have in our jobs every day to begin with, and you've got a really tough situation to manage. And it's one where, again, that sense of internal inconsistency, and people feel somewhat fraudulent. They feel like they're being dishonest, and at the same time, they feel like their responsibility is to again keep that face and that mask on. So again, it generates anger, it generates frustration, sadness, all these emotions that only worsen the situation. And I'll just mention, as part of this discussion on this point, that this is a not subtle plug for psychotherapy and for mental health treatment. I mean, even if you only have one place to take that mask off, the pressure valve that can be released by having someone who really knows what you're going through, who can help take on some of that burden in a professional sense and allow you to recharge in that capacity, and then feel a little bit different about the way you go back to your job or back to your family, knowing that there's a plan in place so that that's not indefinite, so that you aren't doing this for perpetuity. Because again, I think a lot of what people feel about their lives and their mental health when they reach the point of suicide is that there's no way out other than suicide. And again, part of mental health treatment is finding different avenues to deal with these issues, finding creative ways by essentially bringing another professional on board to help consult and think about things differently moving forward so it doesn't feel so permanent.
And I would assume that part of the key is to be getting help early before you get to that abyss where suicide feels like the only option. I remember talking to a friend of mine about my dad's death. And as it turned out, my friend had suffered from really serious depression. And I remember him telling me, Sally, when you are in that really dark place, suicide doesn't feel like a choice to you. It feels like the only choice. And once you've gotten to that point, certainly help is there. But gosh, if we can get folks to have some intervention before that. I would imagine that all of you all wish that you had not had to live as long as you did, suffering the way that you did.
Yeah. Yeah. I mean, when I look back on it, I probably lost half my life, 30 years being miserable, and not even, and that's a lot of time to have lost to if I could have done something else and actually been interacting with people rather than going home and going to bed, and stuff like that. So, but you're right.
Eric, and was I understand that you all discussed sort of the dilemma of when or whether you need to disclose to clients that you're struggling. How did you all work through those issues?
There is no answer. Is the short answer, and a lot of that is an ethical discussion as opposed to a professionalism discussion, and so don't want to focus on that a lot. But what I will say has more to do with stigma and disclosure to the world. There was a question out there about attorneys being fearful of letting people know what their background is here. I speak now to the 45 people out there who checked, yes, I have attempted. 47, 48, counting the three of us. If you talk, people will know. And guess what? It doesn't really matter. In the last 6 years, I have lost no legal work for people knowing, and I'm very public about it. It's not a matter of disclosing. It's just, this is my story. I have lost no referral sources. All of my clients who were with me before came back. Only two opposing counsel lawyers have created any problem. One was a guy who was trying to get me to, I'll use react, break down, act out in court. And it was so bad that even my client asked what the heck was going on. And it didn't matter, asterisk, I won the hearing. Second lawyer on the phone with me, and this is almost funny. They're going back and forth, and this lawyer says, well, I know about you, which is about the funniest statement in the world because I speak on this how frequently everyone knows about me. Those two lawyers are the exception. I'm going to give a shout out to another lawyer, Lee Hart at Nelson Mullins. After a big hearing that I came in on, that he'd been on the case for a while, he called me after the hearing. It went better for my client than his, and said, I didn't know who you were, so I looked you up. I see what your history is. I just want to tell you how good it is you've come back from it. The guy on the other side, he has no need to say that. So don't be scared. We get it. We help each other. We're all crazy anyway? I don't know.
Crazy's not a medical diagnosis. Okay,
neither is confirm that fact.
Neither is lunacy. Okay, may have been 150 years ago.
Does Meshuggah work? No,
Michigan might work in the right situation if there's a little schmutz around.
there you go.
So Sally, what I will say about disclosure is I am not sure. I know I talked to friends of mine about it, and so they knew. But about being as open and public as Eric has been for a while, I don't think I was. In fact, I'm positive that I wasn't. But once I took the bench and I saw defendants and folks who were experiencing similar experiences as I did, I made the decision that I was going to talk with them about it from a place of knowledge, so that I wasn't just talking at people, so that I could talk about my own side and say, look, I understand you're having this experience. We need to get you some help and mental health. And what I have tried to do, and since I've been a judge, is to destigmatize mental health with any of my defendants, whoever it is, because I'm a survivor of it. I mean, the reason I'm here is because we had an EAP program at Troutman Sanders. Without that, I don't think I'd probably be here, quite frankly, because it was free. It was easy. I just called up, see me, and then I got the referral. But that's why I'm very willing to be open about it, is because, you know, somebody talked about weakness earlier, and, you know, it is, I know this is going to sound really strange potentially, but being successful at suicide, you might call it weakness. It's easy to say that from the outside, but when you're in it, that seems like the strong choice. So for many people, I'm sure it's not everybody, because we talk about succumbing to this or that. It's like things beating you down. For me at the time, it was the strong choice was to take myself out of the equation. The only thing that really stopped it was, this may be TMI, but it was, I couldn't figure out how to do it in a way that, one, I was truly going to be successful, because there's lots of problems with attempting and bad things that happen to you if you just attempt. And so, and two, since I had decided a shotgun approach was the best approach to be successful, where was I going to do that without having my family find me, or people that, you know, you care about finding you? And so that's what kept me from doing it. But it seemed like the strong choice until I realized it wasn't. So that's why I talk about it now for folks, because I think there's a misconception about what folks are going through and how people think about it when they're thinking about suicide.
The decision to attempt it was one of great clarity and confidence. I didn't have to spend any time choosing the method, because I had, like Wes, having thought about it, worked through the ones that wouldn't work for me. I got to the office. What looked like a glass of water was a glass of vodka, and there were pills. I won't get into that part anymore, except to say this: I had a to-do list that day. First, I realized I had Braves tickets for the next day's game, and I had to put those up on StubHub. Interestingly, my gain on those tickets paid for my visit to the special hospital. Second thing I had to do that day was I was on a judge's calendar. We had a hearing, and I forget exactly what it was, but I called the judge's chambers, said I was not feeling right. Can I submit on the papers? Judge said, absolutely. Other side didn't show up. Judge Taylor signs the order. So on the day that I tried to do what I did, unbeknownst, we didn't know each other at the time, he's granting my client some relief. All of these things were things that made sense to do while I was attempting, because it wasn't, I'm going to go to the abyss, or whatever word you use. It was, this makes sense. And you're thinking so clearly, and by clearly, I mean so backwards and messed up, that it makes sense.
Go ahead, Mark.
No, go ahead, Ben.
I was going to say, during our planning meeting, I know Eric and Wes, you guys discussed a really important point that I thought we might highlight right here, which is the way you were thinking and the distortions you had in your mind about your family or other loved ones being better off if you were to die, and the way it feels now. And I wondered if you might want to highlight that. I mean, I imagine a lot of people have given themselves the rationale that, you know, the world or their family would be better off without them. I mean, what are your thoughts on that at this point?
Yeah, I was convinced.
Yeah, I mean, that's Wes and I are both capable of talking in long paragraphs, but it's just a very straightforward answer. That's what was true.
And I guess just pointing out, I mean, how distorted that feels at this point, you know, having sought treatment and no longer being in a state of depression, realizing how much that state of mind is hijacked by biological depression and all the constructs it creates. You know, we hear that quite a bit, and, you know, the rationale is often something along those lines. If people look back afterward and say, you know, once they've received treatment, it's, you know, I can't believe I was that far down that path, and I can't believe I was able to, you know, work myself into that type of a position mentally to believe that would be the right outcome for my family.
Okay, maybe I can pitch in right here. First thing is, Wes, I'm very glad you didn't choose the method you chose, because you would have created a lot of work for a lot of medical professionals. Sorry about that. But I mean, yeah, you're just, I thought it was this. The truth is that when you're really down and depressed and low, people say, oh, suicide's not a solution. Well, it is. You're in so much psychic pain. The solution is to get out of the pain. It solves the problem of pain. And it's the wrong way to solve the problem, but that's the solution. So I think I'll get into another thing, just because it goes along the question of whether people will miss you. So my method of attempting suicide is really different than what the other two have said. I did a very passive approach to suicide. I was a doctor working at, I worked at the VA in San Diego, and I was working over a long 4-day weekend on the millennium, the first millennium, you know, and I saw a patient who had gotten flu, got better, gotten pneumonia, and come into the ER. You know, one of these patients that the nurse goes that way, and you sort of do the about face and follow the patient, because it's kind of an uh-oh moment. And the guy was sick, and I intubated him, meaning I put a breathing tube in him and put him on a machine, and he rolled up to the ICU. And a week later, I had a cold that time. I got sick, and I got sick, and then I got sicker, and I got sicker, and I knew how sick I was. And instead of going to a doctor, I decided to stay home. So rather than seeing anybody, I just decided I'll stay on my couch, and I'll just, you know, probably have a little problems breathing, which I did. And that'll be the end of it. And so I must have, there's a little part I didn't tell before. You know, doctors get to write prescriptions for themselves. So, but they're not supposed to write prescriptions for controlled substances. But I managed to write a prescription for a cough suppressant that had codeine in it, and went to the pharmacy, and the pharmacist yelled at me. So, you know, you can't do this, you can't do this. But I must have looked pretty crappy because she gave it to me. But so I did that, and somehow a friend came over and found me and thought I was acting really strange because I was looking for my wallet in the freezer. And, you know, it's like, well, that's not a normal place to put a wallet, at least not for most people. You know, maybe there's some crime families that, you know, store their cash in cold places, but not most people. And so I ended up going to the hospital, and my first sentence to the doctor there was, I think I need to be intubated, which means I think I need a breathing tube, which is exactly what happened. So I ended up on a vent, in an ICU for a month, on a vent for 3, weeks and on basically cardiopulmonary bypass, which means they took blood out of me and ran it through a machine to oxygenate me and put it back in. So I would have died 21 years ago if that hadn't happened. I realized I thought nobody cared. I thought nobody would miss me. I didn't think my life mattered. And what I realized then is that lots of people would miss me. My family came in from all over the country. The hospital I was in, the room I was in, the ICU nurses got so overwhelmed with calls from my colleagues that they said, stop it, designate one person to call once a day. We'll give you an update and then you can tell everybody else. I had patients visit me. And I had a janitor who worked in the VA at nights who came and visited me, which was completely unexpected. I asked him why he visited me. He said, you were the only doctor that ever talked to me. Like, okay. So, you know, right now, I know that people would miss me. My wife would miss me. My family would miss me. Colleagues would miss me. So it was sort of a realization that, okay, I was wrong about all of that. And it took something drastic to actually like enlighten me. So I don't know about how, you know, Wes, you know, felt about that or anything, but that's, you know, I mean, that's what I did. And it's a kind of, I think what did you say the other day, Wes, about the way I forgot what you said.
I said you were really smart about how it was a brilliant way to do it. I mean, it was just something I would never have thought of. And
yeah, it would have looked like a natural death.
right.
It would have said natural causes. I've signed enough death certificates. It would have said natural causes instead of suicide. And, you know, that was it.
So you had essentially a Jimmy Stewart, It's a Wonderful Life experience for real.
Yeah, well, I hadn't thought of it that way, but yeah, exactly.
You all obviously ultimately sought treatment. How did you find the right healthcare providers and medications to help you through this?
Trial and error on both parts. The meds are an easy one to describe. There are, I don't know, Mark or Ben, 16,000 different things that you can be given in 42 billion different combinations.
Ben can answer that.
Yeah, you know.
Roundabout, yeah.
Yeah, and so it took about a year and a half of mixing and matching, some of which did nothing, some of which have you breaking down in tears. Once they got the cocktail right, since then it's been a matter of, well, let's up this and down, you know, it's tweaks from that point on. Ultimately, I decided I wanted the person doing my meds and the person speaking to me to be the same person. I didn't want to go to a meds guy once every 3 months or 15 minutes. So to find someone who does that, who is on your insurance and who has available time is a challenge. It takes time. But once I went through that and found a couple of people to look at, I succeeded.
What about you, Wes?
I hate to say this, but I guess I was just really lucky because I went to EAP and I just looked at folks who were close to me, and there was somebody in a little house over near the PDK airport, and that's where her office was. She was just a therapist, not just a therapist, but she was a therapist because it was the EAP. So I went to see her and we had some good discussions. I enjoyed those. And after, I think maybe one or two of those, she said, you might want to see a psychiatrist about this. And so I think she recommended the psychiatrist is what I would expect. And we had, I'm not doing any plug, but we had one of the giant insurance companies here as our provider. No, it was Anthem back in the day, and that's what I have now. And you just look them up, you call them, you go in. There was no problem at all. And I I saw a psychiatrist who did my meds at the same time and talked to a psychiatrist, or maybe somebody in there. I think I talked to a different therapist, but it was in the same psychiatrist's office, and I saw the psychiatrist and then I saw the therapist mostly. But they were both great. We talked through things. I had to change meds a couple of times up. But then for me, and I think I saw a chat about, do you ever get through it? I mean, for me, I guess it was a little different on how it came about and how it resolved, because now I don't take meds now, and I don't continue to see a psychiatrist or a therapist. But I will say, even on the bench, I haven't talked about this, but I have used the lawyer assistance program, and I had anxiety issues. I kept going. I was having heart issues that my doctor said it was just anxiety. So I said, maybe I ought to see somebody instead of my doc about this. And so I did, and had a few sessions through the lawyer assistance program, and I haven't had any heart palpitations since then. Changed my diet a little too, but it's so I found it pretty easy, quite frankly. But I guess not everybody does. But mine was. But I kind of trust who I get referred to.
So the phrase we use is play with the meds. So Ben can probably testify to that just a little bit, but he can also testify that doctors are horrible patients. Okay. And I mean, I'm a horrible patient. We think we know everything. So we diagnose ourselves and we treat ourselves. And so I went on and off medicines a bunch and went through some psychiatrists and several therapists. And at the end, I basically said, okay, I need to take some time off, and took FMLA through the hospital I was at, and got a psychiatrist, and actually got another therapist. And that helped a lot. And so I was in Dallas at the time. I moved to here because my wife got a job at CDC. So I moved here, and I would go, if I had the time at the moment, I would probably be doing therapy as well, because I think it helps. But right now, I don't have the time. I just can't make the time during the day to do it. And that sounds bad, but that's the way it is. I would actually recommend some people get okay with meds, but I think that actually the combination actually works a lot better, at least in my experience. So Ben, return.
Yeah, there's great evidence to support what you just said, Mark. It is a process of trial and error. I think one thing to keep in mind for anyone who's seeking treatment or otherwise helping other folks they love seek treatment, it often takes a few different combinations of medications and or providers to find someone who really can get you to the point where you feel comfortable and that you feel like they're hearing you and hearing you fully and understanding what you have going on and how you're reacting to those medications. And that's, I think, a little different than some areas of medicine. If you have high blood pressure, it is a lot more formulaic. It's a lot easier to pick out some medications, and you will probably get a response much quicker. Be patient. If you don't feel like you're connecting with a provider, get a second opinion. I think that's really important in psychiatry, especially with so much subjectivity to the experience people are having. So it's not uncommon to go through a few medications and a few different docs or therapists to find somebody who really feels like you can connect with them. I think the other thing too that we've mentioned a little bit here is the difficulty sometimes of finding good providers in network with the insurance companies that people are dealing with, or even through EAP programs. The truth is, and this is not the time to go into a discussion of insurance reimbursement, but I think I would say it's safe to say the majority of your strongest providers often have to consider whether they want to be in network or if they want to work in private practice without in-network privileges. So, I wouldn't necessarily stop at your insurance company's list of psychiatrists or therapists if you're really looking for the best care and you feel like you're not finding it. It is a little more expensive, but it is usually an investment that's well worth in terms of your productivity, if nothing else, work-wise, but most importantly, your health and well-being. And again, there's a lot of great docs who we work with regularly who just unfortunately can't accept insurance and keep their shingle up. So If any of you want to advocate for us down in the Capitol, we'd love that too. But I think, keep your mind open about trying new providers. If you're not feeling like your medications are working and you're kind of stuck, go see another provider. I think that's something we all expect at certain points. I feel very confident in my ability to follow treatment algorithms and hear patients, but occasionally there's just somebody you just can't quite connect with. And I think the most humble and helpful thing to do is often refer them to someone else to get a second opinion. So again, just don't be frustrated. I think that the hopelessness factor can come in really quickly when one or two medications doesn't feel like it has the effect that you're looking for. Stick with it. I think that, the median time to improvement is a little bit longer with psychiatric issues, but we are very successful when people follow that evidence-based algorithm of, again, medications and usually psychotherapy, along with some other practices that were actually mentioned in the questions I saw, like mindfulness and nutritional counseling and exercise. I mean, it's really a holistic approach with mental health, and stick with it if you're not feeling like the results are there right away.
Yeah. So the therapy that worked for me at the end was something called cognitive behavioral therapy, which does include mindfulness and stuff like that. And I do exercise every day. I'm just going to make an aside on Ben's comment about insurance companies. Talking to them does not make me suicidal; it makes me homicidal. Sorry, it's frustrating. Now, there was a question in the chat about curing and stuff like that. I think for Eric and I don't think there's a cure, because I started young, he started young. This is like high blood pressure. This is like, it's basically a management issue. If I go off meds, at some point, I will get depressed. Wes, on the other hand, might be a different not a different problem, but a different situation, because, maybe Wes is a different problem anyway. But, he might be a different situation because of how it happened. What do you think, Wes?
I'm no doctor. I'll let Ben for free psychoanalyze me, or we can put this into my insurance. But no, I think my situation has been a little bit different than yours and Eric's, and so I think mine was basically brought on because of trauma, quite frankly, and I know just enough to be dangerous about this, dealing with accountability courts and mental health courts, and just from being a lawyer on this, but I think it's a little different than y'all's.
I think that, I'm sorry, a lot of it has to do with how you phrase the disease or phrase the problem in terms of cure. I think that what I was suffering, a word I don't like, from before was a lack of knowledge. Okay, I went from that lack of knowledge and I picked up self-awareness. That cured my lack of knowledge. Let's forget that it's a brain issue and think of it as an ankle issue. If you don't know you have a bad ankle, and you cramp it the wrong way while you're running, your ankle blows out. Now you know that you have a bad ankle and you take care. That won't happen to 99 out of 100 people, but it'll happen to you because you have a bad ankle. For me, the cure was self-awareness. I know what the signs are. I know what the dangers are, I hope, and I avoid them, or I respond to them. I take a step back. One thing that the drugs help with is that extra 2 or 3 nanoseconds of thought before action. So the cure is really awareness, not changing the chemical underlying problem.
True.
And we have some questions in the chat that are from folks, for example, who may live in small towns where there aren't a lot of mental health providers. And specifically some questions about telemedicine that has been permitted during the pandemic, and whether that is something that you imagine or foresee will be continued in the post-pandemic world, which could be really helpful for people who really don't have access to the right kind of providers. What are your thoughts about that?
Yeah, I think our opinion on this as a field has changed quite a bit since the beginning of the pandemic. I would say, there aren't many blessings of COVID, but I think one of the things that has come up is, number one, an increased attention and awareness of mental health issues, especially given all the different, methods of achieving wellness that have been stripped away from us, and how many people have realized they've, started to feel depressed and anxious and many other things. But also, bringing telepsychiatry and telemedicine to the forefront and realizing how feasible this is for many situations. I will say that I think in-person treatment is the premium kind of best way to do treatment if you have access to it. But we have, even in our program, we never imagined doing virtual treatment, and it's been incredibly successful. And we've been able to connect to patients, and in many cases, for me now, doing therapy, I prefer to have somebody on Zoom and not wearing a mask so I can actually see their facial expressions, as opposed to in my office with a mask on. But I think the other thing is, from a reimbursement and legality standpoint, it really looks like this is going to be continued past even the pandemics. Who knows when the actual conclusion of this is going to be, but I think it's going to be something that sticks around, because we've seen how useful this is to patients, and how much it helps docs extend and see more people and provide care to more folks. So yeah, if you're in a location that does not have a lot of resources, health-wise or mental health-wise, look into your options for telepsychiatry. There are lots of docs who are willing to do this, and quite frankly, a lot of them do it at a reduced rate for telesessions, just because it is so efficient. So again, it may require a one-time trip to go see that person to make sure that they've been able to assess you in person, but with that investment, you might have a doc who can take care of you for years, and from the convenience of your office or your home. So absolutely something I'd advocate for, and again, try out if you can't find a provider near you.
And for the person who may be looking for a mental health provider for the first time, are there certain key factors that you think they should be considering in identifying the right provider for them?
I think, beyond, and I will say, I still look up providers on Psychology Today if I'm looking for providers in outside cities. It's not the most elegant method, but it ends up giving you a good picture of people in many cases. Looking at training, I think everyone here is probably capable of looking at someone's resume and kind of seeing where they've trained. I think the likelihood of somebody following the scientific evidence and research information in making treatment decisions is higher if they've trained at a place that has that kind of high quality training program. And these are the hospitals you recognize, the universities you recognize typically. But beyond that, I think the most important thing, honestly, and the factor that mediates treatment outcomes to the highest degree in virtually every study that's ever been published is rapport, and feeling understood and feeling heard by your provider. So again, this is where you can have the most brilliant doc in the world, but if you don't connect with them, if you don't feel comfortable letting them know where you are, how you feel, then the treatment's never going to be optimal. So I think make sure you feel like you're comfortable with someone, and then again, you should be able to ask them what their rationale is and sort of what the scientific evidence is behind the treatment decisions they're making. If they're in psychotherapy, they should be using a modality like what Mark mentioned, cognitive behavioral therapy. A great place to start for virtually any condition, by the way, is cognitive behavioral therapy. A lot of new wave cognitive behavioral therapy includes mindfulness-based techniques as well. But start with someone who can tell you which model of therapy they use and should be able to walk you through how that model of therapy is supposed to be delivered. So the biggest issue that comes up in therapy is that there's a very little oversight, and people end up in a chair across from a provider for years just kind of talking about how things are going and not actually doing therapy. And that is not what therapy is. Therapy should challenge you. It should open up new ways of thinking and new perspectives. If you're not being challenged and you feel like you're kind of just going in and there's an aimless hour that you spend, feeling generally supported but not otherwise pushed, I think that's probably not good therapy. And again, you should be able to ask them what their theoretical approach will be and what their goals are moving forward.
We have a question from an attendee that it's as follows. I'm afraid that if I talk to my loved one about suicide, it may introduce the idea and make suicide more likely. What are your thoughts about that?
Yeah, so exceptionally well-studied topic. We can definitively say at this point that is not the reality. So talking to someone you care about suicide, asking them if they're thinking about suicide, asking them, if it's something they need to be concerned about, what you need to be concerned about in terms of their safety, does not introduce the idea of suicide. Again, this has been studied time and time again. What does happen, though, is in many cases, it allows that person to realize that suicide is something you're willing to talk about with them and help them find support. So, again, it is fundamentally destigmatizing it by bringing it up to them. Make sure that when you ask someone about suicide or harming themselves or feeling unsafe, that you're also available and willing to actually hear the answer. I think that's an important thing too. I think you need to be there and be present. But I mean, the number of people who have reported to me, when they have suicidal ideation, that one person who asked them how they were doing and asked if they were okay, and frankly asked the question directly about suicide and how that saved their life. I mean, I can't possibly count at this point. So, this isn't anyone's responsibility, as we've said, multiple times throughout both these panels. It's not anyone's responsibility to prevent anyone from dying by suicide. It's an incredibly complex phenomenon, and often the risk factors are not obvious. But if you ever feel like there's a good reason to ask someone about their safety, please ask that question as directly as possible, and please involve professionals as soon as you can. It absolutely will save lives. It will not introduce the idea of suicide.
Yeah, I was going to say, if they're thinking of suicide, they're already thinking of suicide. It's already come in, and it's not going to go in at your suggestion. It's already there.
May I add just a couple of things there, though, and Dr. Hunter, you tell me if this is wrong, though. I think for folks who ask about it to a loved one, I think what Dr. Hunter maybe minimized a little bit, but what we're hoping to do by having this discussion, at least what I'm trying to do, I think what Eric and Mark are trying to do, is to destigmatize the fact that you're thinking about suicide and the fact that you have had the thoughts. That doesn't make you weak or a bad person or incapable or somehow lesser than everybody else. It just means whatever it means. Sometimes a chemical brain imbalance, something else. But if you're gonna ask that question, you better go in, at least this is my thought, of being non-judgmental about it. And so if somebody says, yeah, you better be prepared not to say, what do you do? I mean, it's just, I think it's better be prepared to be accepting of the fact and not to judge the fact that somebody's thinking about suicide. You can have thoughts of, I don't know, that was my thought. Eric, what do you think?
I was at a seminar, for lack of a better word, yesterday, put on by 2 or 3 big firms about taking the ABA wellness pledge. Now, it was about wellness, and we've got 1 minute left, so I'll talk quickly. I asked the question to everyone, has anyone at your firm, and that statement included about 2,500 people between the 3 or 4 firms that it was, attempted, and if so, are they out about it? And the answer was no. Well, we know with 1,500 people in the room here, we have 40 some odd attempts. If those people at the big firms would come out and say to everyone else, hey, this is a real issue, people would react. One quick thing in conclusion for me, there are a ton of unanswered questions in the chat. All of our email addresses are available. Mine's in the materials. And send them to me afterwards, and we'll answer them.
I want to thank all of our panelists this afternoon for so unselfishly being willing to share with us. I'm confident that you have really provided help. There were over 1,900 people who signed up for this event today. Think about that, 1,900 people in the Georgia legal community. And while, look, I totally get that some people just need CLE credit, but there are easier ways to get CLE credit.
I don't get that.
3 hours talking about suicide. So I think that tells us that this really is an issue that our society is grappling with and that our friends and colleagues in the Georgia legal community are grappling with. So we are very grateful to you for, as I said, your really generous willingness to share with us today. Thank you all.
Thank you so much.
Very, very welcome, and I'm glad to have been invited by Carlise and others.
Thank you.
Well, I will now turn it over to Judge Hurd, who will introduce panel 3.
And I'm sorry, Ms. Yates, an update. Judge Hurd had an